Hi, I'm Elizabeth Lindsey. I'm one of the gastroenterologists here at 𝐓𝐚⁴ Health, and you're listening to Health Talks from the Inside Out.
Dr. Elizabeth Lindsey, you are a gastroenterologist with our 𝐓𝐴 Health Medical Group. Thank you so much for joining me on the podcast today.
Thank you so much for having me. I'm excited to be here.
So when you started medical school, did you have any idea that you might want to go into gastroenterology? Or if not, how did you get there?
I come from a family of doctors, my dad and my great-grandfather. My dad was a cardiologist, so I honestly kind of thought I was going to do that for a long time. And then reality hit. I had a baby during my intern year and just realized that I needed to kind of rework my working hours and lifestyle, and GI offered that. GI is nice in that it's like cardiology. There are plenty of procedures, but then there's plenty of office-based work, a little bit of hospital work. So yeah, it just kind of fit my needs at the time, and then I've just come to love it.
Yeah. So what all, and I know you hit on a little bit of it just then, but what all does this specialty of gastroenterology entail? What all organs?
Right. Yeah, so the GI tract is very extensive. It starts with the esophagus, which is more in this area. I don't take care of the mouth. A lot of patients come in complaining of more ENT related issues that we end up redirecting. But I take care of issues that start in the esophagus. So difficulty swallowing would be one for example, getting food down into the stomach. So it's esophagus, stomach, small bowel, colon, rectum, and then in between liver and pancreas. So disorders of all of that.
So within that extensive GI tract, is there something that you find very fascinating or cool, exciting that you can share with us about our GI tract?
Where do you start? There's so much. I think just little facts like it's 30 feet in length, starting from your mouth to your 30 feet. Yes, yeah. We have about 22 feet of small bowel, about 5 or 6 of colon. The small bowel, out of all of them, I rank the small bowel actually pretty high in that it has this fascinating absorptive surface covered in these little finger-like projections called villi, and they increase the absorptive surface of the small bowel. When you stretch all of the little villi out, it's something like 2,700 square feet or that of a tennis court.
Wow.
So the small bowel has amazing absorptive power for fluids and nutrients.
That's very cool.
It's really an underrated organ for sure.
I like it.
Yeah, underrated.
Okay, so a few terms that I'm kind of hearing out there with regard, I guess, to the GI tract. Gut microbiome and maybe just overall gut health. So can you walk us through kind of what those phrases mean, what that includes?
Yes. Yeah, so the microbiome, it refers to trillions of microorganisms that we have living on us and within us.
Wow.
And those organisms are anything from bacteria to viruses to fungi to little baby worms, helminths. It really is kind of fascinating.
Yes.
We've got a microbiome on our skin. We've got a microbiome in our nose and our mouth. We certainly have a microbiome in our small bowel and our colon. Females have microbiomes in their vagina. But yes, it's a fascinating area of research and attention, for sure.
I would assume lots of those organisms are supposed to be there.
Oh, absolutely,
but some are not supposed to be there?
So we have ones that are commensal, that are just kind of living and existing with us. There's definitely some that are symbiotic, that are working to help us. And then yes, we have this kind of low grade level of pathogenic organisms, and those are the ones we obviously want to keep at bay. The trillions of organisms that we have living within us, they certainly play a very important role in many things. They modulate just normal physiological functions such as digestion, absorption of nutrition. They play an intimate role in maintaining the integrity of the lining of the GI tract, so keeping all the bad things out of our body and within our GI tract so that we can expel it. And they play a big role in metabolism. They are intimately related to our immune system. In fact, the highest concentration of our immune system is within the GI tract. So the idea is that those organisms are modulating our immune system, maintaining homeostasis of our immune system. They play a big role in modulating chronic disease, such as type 2 diabetes, heart disease, obesity, autoimmune disorders, such as inflammatory bowel disease. They can turn on and off genes, which is fascinating to me.
All of that is fascinating. I had no idea. So what influences our gut microbiome?
Right, so many things. From just how we are delivered at birth. I mean, truly, a cesarean baby has a different gut microbiome than a baby that's delivered vaginally.
Okay.
Yes, where we live in the world plays a big role. Environmental influences, our age, our gender, our ethnicity, certainly our diet is a big one, for sure.
So how do we know if we have a healthy gut?
It's a great question. I mean, it's certainly all over the internet, all over magazines. Patients come in and ask me all the time. But that is the $60 million question. Right now, it's not straightforward. There's not a perfect blood test that allows us to tell you what your microbiome is like, what organisms make it up. There's not a poop test. It certainly may be on the horizon. I think we all would like to know how to manipulate our microbiome so that we can have overall health, but it's just not there. The way I think about it is, if you don't feel well from a GI standpoint, you have a lot of gas, bloating, diarrhea, constipation, you might have an unhealthy gut or an alteration in that microbiome.
So it's more of kind of a gut feel, if you will.
Maybe that was good.
Maybe that's where that phrase comes from.
Well, that's brain gut. I think that comes about because there truly is this brain gut connection.
Yeah. Okay, so you're saying our brain and our gut. Okay, well, tell me a little bit more about that.
Intimately related. Intimately related. So 60 to 70% of our body's serotonin, it's a neurotransmitter that plays a big role in our mood, but it also plays a role in pain and sensation, it's housed in our GI tract. We make most of our serotonin that we have circulating in our body in our GI tract. So that certainly feeds back up to our brain, and then the serotonin here and nerves feed back down to our GI tract, and a lot of times it's through the vagus nerve. But yes, absolutely, the brain-gut connection or the gut-brain connection is real. The GI tract is known as the second brain. We have the second highest number of nerve cells in our bodies within the lining of our GI tract, second to our brain. There's just a lot of activity going on there that sends signals back up to our brain. And certainly when we feel anxious or worried or depressed, a lot of patients, me included, will have GI symptoms. So it's an exciting area of how can we intervene and help these patients, and how is the microbiome playing a role in that brain-gut axis.
So you mentioned a few symptoms a minute ago, whether it was gas, bloating, diarrhea, things like that. What are some of the most common symptoms that someone might realize that they have going on and think, I might need to reach out to a GI specialist to see?
So kind of starting at the top, I see a lot of patients with heartburn or acid reflux. Definitely difficulty getting food down. That's called dysphagia. Certainly abdominal pain, probably one of the most common things I see. Patients with abnormal liver tests, and a big reason for that is fatty liver. Fatty liver is kind of the colloquial way of saying it. Kind of the more medical term is MASH. So metabolic dysfunction associated steatohepatitis. It just really refers to fat residing in the liver causing inflammation. A lot of bowel issues, so a lot of diarrhea, a lot of constipation. But then little things like bloating, belching, burping, flatulence, anything in between. I'll take care of it. I'll see it. I love it.
You see it all.
That's right.
So when a patient finds their way to your office, how do you work them up? How do you diagnose what might be going on?
Right, absolutely, yeah. So much of our job is doing procedures, is looking inside the GI tract to try to come up with, why. So a really common procedure is an upper endoscope, so it's called an EGD, esophagogastroduodenoscopy.
Wow, okay.
So it really means that I'm looking in the esophagus, the stomach, and the first part of the small bowel. Oftentimes I'll do that procedure for ongoing heartburn, acid reflux, regurgitation, certainly that dysphagia, difficulty getting food down. A lot of procedures are done for epigastric pain, looking for gastric erosions or ulcers that might come about from taking aspirin or non-steroidal medications. A lot of patients complain of kind of nausea and that ick feeling, diarrhea. I'll do an upper endoscope for those symptoms as well, looking for celiac sprue. There's a newer kind of understood entity called disaccharide deficiency.
Okay.
Patients don't have enough of certain enzymes to break down sugar carbohydrates. Okay. So I'll do an upper endoscope, biopsy the small bowel, lactase levels and sucrase levels can be directly measured. And that can help me explain to a patient why they may not tolerate certain sugar carbohydrates.
Yeah, okay.
Another big procedure is the colonoscopy. Certainly do it for screening purposes to try to detect early cancer, detect polyps that could turn into colon cancer, but do a lot of diagnostic colonoscopies for diarrhea, for bloody stool, for change in bowel habits. So someone may come in and say, oh, I was regular for years and years and years, and why all of a sudden am I constipated? This is so crazy. I've never had a problem having a bowel movement. Now I'm straining, and bowel frequency is infrequent. Definitely a colonoscopy for that.
Okay. Well, and so we've talked about colonoscopy, but that is one thing I really wanted to hit on because March is Colorectal Cancer Awareness Month.
Yes.
And you said it just a minute ago, and I love every time I hear you say this, so I want you to explain it more for our listeners. That a colonoscopy doesn't only diagnose cancer potentially, but it can actually help prevent it.
Correct.
So can you explain again what that means?
Yes. So the whole idea of a screening test in general is to detect the precursor to the cancer that we're trying to prevent with that screening test. We get pap smears, we get mammograms, and the idea is that you want to pick up those cells before they turn into cancer. So the same exists for colon cancer. The precursor to colon cancer is the colon polyp, and the technical term is the adenoma.
Okay.
And so the idea of a colonoscopy is to look for polyps. And so if I see polyps, or any of us see polyps, our goal is to remove them. And now it's so exciting. Newer data has demonstrated that removing precancerous polyps not only reduces risk of developing colon cancer, but it reduces risk from dying from colon cancer. It's exciting.
It is exciting. Time. And just because I'm wondering this technical question, how do you remove the polyp?
Right.
You know, you're in with the scope, but what other instrument is in there? Like, how are you removing it, and then what do you do with it?
Yes. So the most common tool we have is a snare, and I describe to patients it literally looks like a little wire lasso. And we feed it through the scope, and it comes out the end of the scope, and we line it up and hopefully just lay that lasso around the polyp, and you can either snip the polyp off kind of cold without using cautery, or we have cautery if we're worried about bleeding, or if it's a bigger polyp. And we've got some other little techniques we can use to ensure that they're safely removed. Inject some product underneath the polyp to lift it away from the muscle layer to reduce perforation. But all in all, it's actually pretty simple and straightforward.
And how big, or how small, I guess I should say, are they? What's the size?
So, we can detect 2 millimeter polyps. I mean, obviously up to several centimeters, but yes, our cameras are high resolution. We're looking on a big screen, so we're very up close and personal. And in the world of polyps, average is several millimeters. When I tell patients, oh, you had a centimeter sized polyp, and if you think about a centimeter is tiny, that in the world of polyps is actually considered big. So once they get that centimeter mark, as they grow, there is that chance that cells can degenerate into dysplastic and metaplastic and cancerous cells. So we always want to get them before them.
And so once you get them out, once you've lassoed them and you get them out, do you send them off for testing?
Everything goes to pathology. Yes. And pathology, they give us a report, and it's what type of adenoma, is there any evidence of dysplasia, which is that kind of marching towards cancer, or is there cancer? And usually, I mean, so much, again, of what we do is visual. So many of us, if we see something that looks like cancer, we can pretty much go ahead and tell a patient. So usually patients are leaving knowing what's going on.
And what is the average age that someone should come in and get a colonoscopy?
Right. So several years ago, the age dropped, luckily, to 45, and that was because we are detecting cancers at earlier ages, and unfortunately we're detecting cancers that are in more advanced stages at earlier ages. So luckily the guidelines changed to 45. So now for average risk, it's 45. If you have a family history, we're wanting you to come in at 40. But let's say you have a family member who had colon cancer at the age of 47, we would dial it back 10 years in family members. So 37 for a family, 37 years old for a family member. There are always other exceptions. If you've got an inflammatory bowel disease, you're probably going to have a colonoscopy sooner. If you've got a genetic predisposition to colon cancer, such as Lynch or FAP, familial adenomatous polyposis, you're probably coming in earlier, more often.
And you said average risk, 45. So what exactly does average risk mean? We don't know of any other factors. So
correct. Average risk means no family history. Right, and you yourself have no predisposing medical conditions, like I said, such as inflammatory bowel disease or genetic disorders.
So if you've made it to 45, your average risk, you need to go have your colonoscopy.
Definitely.
And then some people, based on other risk factors, might need to come earlier.
Absolutely. Yes. Yeah.
And like you said, it's an easy, simple procedure. I know people get worried about coming in for any kind of procedure, but it is relatively easy. Under anesthesia, you have a nice nap. You feel very rested. How long are the average colonoscopies?
I tell patients 15 or 20 minutes. On average. I mean, obviously, if I'm removing big polyps or need to remove multiple polyps, the patient will get all the time they need. I will take all the time I need, but on average, 15 or 20 minutes.
And of course, you need somebody to drive you and to take you home.
Yes, that's a big one. Yes, because you will have been sedated.
And then, of course, the topic that people most commonly talk about with colonoscopy is the prep that you have to go through. So can we talk a little bit about what we do need to do to prepare our bodies for a colonoscopy and how it's maybe changed, gotten a little easier in the past few years?
So, the colon has to be, like I say, squeaky clean in order for us to safely pass the scope and then to identify polyps. Doing a procedure in an prepped colon is just futile. And yes, the prep has gotten so much better. It is a liquid laxative. My prep is a Miralax-based prep, so polyethylene glycol. You can literally just buy it right over the counter. It has zero taste, so if you mix it in water, it would taste just like water. We encourage you to mix it in an electrolyte-based drink. On the instructions, it says Gatorade. If you don't like Gatorade,
what I did, the cherry frost Gatorade, the white Gatorade.
We now have learned through studies that drinking half of the prep at one time and then half of the prep at a second time, kind of close to the start time of the procedure, that results in a better prep. And really, that second portion is making sure that the right colon is cleaned off. The right colon can harbor these flat, fleshy polyps that are certainly precursors to colon cancer that are easily missed. And so we really want that part of it. We want your entire colon to be cleaned off, but definitely the right. And that second part of the prep cleans off the right colon better than drinking it all at once. So,
and that's just the day before.
That's all the day before. Yes, we give you advice on how to eat in the days leading up, but it's just one day of clear liquids. And then you start your prep at 6 p.m. It's so not a big deal. It just is what it is.
And we hear people all the time saying if they were a little bit nervous going in on the front end and they've been putting it off, how grateful they were on the back end.
Truly.
That they had it done, it was easy, they have peace of mind. And then if you have a clean report, you don't have to come back for 10 years, right?
Yeah, absolutely. 10 years, yes. And honestly, I mean, people are going to have their reasons for not wanting to have a colonoscopy, or maybe they're a little bit sick at the time with a chronic illness. So we do offer non-invasive colon cancer screening tests.
So with March being Colorectal Cancer Awareness Month, it is a great time for people to think about that, consider, and certainly if you're 45 or above, make your appointment.
Yes, for sure. Or if you have symptoms that you've put off talking about, because I never regret doing a colonoscopy for blood and stool ever, even if the patient's 25, 35. And I tell patients that because the best thing that I'll find is nothing. And we just discuss how your rectum is vascular. You might have just brushed up against a little blood vessel and seen some blood in your stool, but we are certainly finding precancerous polyps in young patients. And to have waited 10 years means that patient may have developed a colon cancer at 38 or 40.
You know, and it seems like just maybe in the media or online, social media and that type of thing, we tend to be hearing about more and more cases of younger people getting colon cancer. So it is real.
It's absolutely real. I mean, that was part of dropping the age to 45. The data has demonstrated that since about 2012, there's been a 3% increase a year of colon cancer in patients aged 25 to 49. Whereas there's been a 2.5% drop in colon cancer rates per year in patients older than 65. So it is real that younger patients are developing colon cancer at this alarming rate, truly. And we're seeing, celebrities with it. We all have, friends. I diagnosed a 45-year-old with a very aggressive colon cancer the other day. I diagnosed a 32-year-old with 2 tremendous polyps. It is happening, for sure.
It is happening, and the good news is we have a
tool,
a good tool to identify it.
Yeah, we definitely think diet plays a big role, and there's certainly other modifiable risk factors: smoking, obesity, red meat consumption. But diet of these highly processed foods are certainly playing a role.
Okay, so let's go now into diet. You mentioned that. So what are the things we should be eating, maybe should be avoiding to have the most healthy gut microbiome?
Right. For me, it's easier to start with what we shouldn't be eating. And that is this group of foods called ultra-processed foods. And it really is like the middle of the grocery store. I don't know if you've heard, or on social media, we should be eating the perimeter.
I have heard that,
But it's all the, breads, these breakfast foods, biscuits. It's, I hate to say it, sugar cereals are terrible. Any sort of, granola bar that has high fructose corn syrup, those are just examples of these highly processed foods.
Something that can live on the shelf
for
a
like
really long
years.
time.
And really interestingly, a study just came out that did demonstrate, and it was conducted over like 24 years, where patients were quizzed on their diet. So they would submit a questionnaire on their diet, and then at age 45, they underwent colonoscopies. And patients who consumed a diet that was mainly highly processed food had higher incidences of adenomas, higher incidences of those precursor lesions to colon cancer. So again, it's not like this perfect cause and effect, but it's a pretty strong association, it seems, between highly processed foods and adenomas, colon cancer.
Okay, so let's talk fiber, because I know it's something that we all need. We often have, I think, a hard time getting maybe enough fiber. So what are some good sources of fiber that we can go to?
We want to aim for between 25 and 30 grams of fiber a day.
Okay.
Yes. The easiest sources of fiber are fruits and vegetables. I mean, truly. Other non-fruit and vegetable sources are whole grains, so quinoa, barley, brown rice, flax seeds, chia seeds, all of those are great sources of fiber. Then we have the whole legume class, so beans, peas are also a great source of fiber.
Okay. So what about supplements, either when it comes to fiber or just anything else? Is that something that we need to be taking supplements of any type?
Well, right. I get asked all the time. This kind of harks back to the whole gut health and should I be taking a probiotic to improve my gut health? And we do not know the answer to that question. Again, because it goes back to what is really gut health. We don't know the answer to that, nor do we have a good way of measuring it. We really should just be listening to our bodies, and if we feel good, we assume we have good health, good gut health. But probiotics are having a moment. I mean, it's like $1 billion industry, truly, of supplements marketing these. We'd like to believe they help. There is a lot of data out there in small instances that suggest they can be helpful. But is there this big, beautiful, randomized, placebo-controlled, double-blinded study that demonstrates that it helps with IBS or diarrhea or inflammatory bowel disease? The data is just not there. So I tend to tell patients, if you're interested in one, yes, you can look into one and I can give them some guidance. If someone were to ask me which ones would I buy, I'd probably just look into the ones that are available over the counter. They don't need to be any fancy brand that you order off the internet. But if you happen to buy one of the fancy brands off of Instagram, that's fine too. If you feel good on it, I'm not going to tell you to stop taking it.
So again, I'm hearing a theme with you. A lot of it is kind of how we feel,
Correct.
right?
Yeah.
So it's not...
Listen to your gut.
Yeah. It's not necessarily a right or wrong. It's
Correct.
there are things we can be doing naturally on our own with the
Right.
things we're eating.
Right.
Or augmenting with supplements, but it's all about, at the end of the day, how we're feeling and how everything seems to be working together.
Exactly. Yeah.
Okay, so let's talk about bowel movements for a minute. What is normal in that realm? What should or shouldn't be happening every day?
Right. Again, an individual question that one individual is going to answer according to them. Truly, there isn't necessarily a normal.
Okay.
Yes, ideally, it would be great for everyone to have a bowel movement every day, but I have plenty of patients who come in and say, I have a bowel movement every other day, every 3 days, and I feel great. But then I have patients who say, if I don't have a bowel movement every day, I'm going to feel terrible.
Right.
So then we work on how do we help you have a bowel movement every day. But certainly, too many bowel movements can be harmful.
Right.
I talked to a fella today, and he has 2 to 3 kind of looser bowel movements a day. He hasn't lost weight. He's not having blood in his stool. We did a colonoscopy to make sure he didn't have a diagnosable problem. It's not interfering in his life.
Okay.
Nor does he have any other chronic illnesses that are affected by it. So, we kind of said, maybe this is your normal.
Right. Okay.
And then try X, Y, and Z for him. But then on the flip side, the patient who doesn't have a bowel movement for 4 to 5 days, who comes in bloated and distended and with abdominal pain, that certainly isn't normal for that person.
Right.
And, can I help them with that with laxatives or diet change? Absolutely.
So while it might not be a one size fits all
Correct.
from person to person, I guess what we should be looking out for is changes within our own body.
Yeah, yes.
So if we've been a certain way for so long and then all of a sudden we're experiencing a different pattern.
That could be an
then
alarm
that
symptom.
could be.
Yes, absolutely. That's a reason to come to the doctor, for sure, and talk about it.
So we've talked a lot about some symptoms. We've talked about some of the diagnostic tools that we have. What are some of the most common conditions, whether chronic or not, in the patients that you take care of?
Right. Well, certainly acid reflux is a big one. And our medicines, though, do a fabulous job. So we don't always scope patients for acid reflux. But if we do for truly heartburn or pain, I can truly see like ulcerations, inflammation in the lower esophagus that help kind of seal that deal with in terms of the diagnosis. Peptic ulcer disease is a big one that we're finding. We love our non-steroidals, we love our ibuprofen, goodies, Aleve. A lot of older patients are on their aspirins. We have a love-hate relationship with them. And they help control symptoms and help with heart disease, but they can just rip a hole in someone's stomach and small bowel. So duodenal ulcers, that's definitely a condition we're looking for when we're performing an upper scope. Colonoscopy, because I see a lot of women and a lot of women with diarrhea, there is this condition called microscopic colitis. It doesn't get a lot of press. I tell patients, we do the colonoscopy, I'm looking, oftentimes the colon looks normal, but in someone with chronic diarrhea, biopsy, and under the microscope, it's very abnormal. There are 2 types, lymphocytic and collagenous colitis. They are not precancerous, but they absolutely can cause a chronic diarrhea, especially in older women. There's a great medication for it that we usually can cure it, and patients move on. So that is a relatively common diagnosis. And then certainly in patients who come in with abdominal pain, bloody diarrhea, weight loss, we do colonoscopies looking for ulcerative colitis and Crohn's disease. Those are our inflammatory bowel diseases. They are chronic conditions, theoretically lifelong conditions that require intensive management, monitoring, and usually some sophisticated medications. Another condition that I think about when I talk to patients about symptoms is celiac disease, celiac sprue. It actually affects about 1% of our population, which is not uncommon per se. Usually patients are coming in with bloating, gas, diarrhea. They can have weight loss, iron deficiency anemia. They oftentimes give a family history of it, so it is a genetic disorder. In order to formally diagnose it, blood work can detect it, but ideally we like to biopsy that small bowel. And I was talking earlier about the little finger-like projections, the villi that line the small bowel. When we biopsy the small bowel of a patient with celiac, those villi are blunted. So their absorptive surface of their small bowel has decreased. And so they in effect malabsorb and can have diarrhea. So that's another question I get a lot is, could I have celiac? And the answer is yes, there's 1% of you out there with it. Now, there are a lot of patients who say they just don't tolerate gluten, but now there is good data that does support backing off of gluten can improve a lot of GI symptoms. So we are acknowledging it now.
So how can patients find you if they feel like they're dealing with some of these symptoms or it's time to get their colonoscopy? How can somebody get to you in your office?
Right. Yeah. So obviously we're on the website.
Right. The WilliamsonHealth.org website.
Yes. Yeah. I work with the Williamson Medical Group, multi-specialty group. Some patients may need a referral from their primary care. Others with different insurance might not need a referral and can call directly. I do have a male partner, Dr. Eric Sumner. So if patients would prefer to see a male provider, they're able to. We've worked together for 2 decades now, so we're kind of the same. We're seeing patients all the time, always taking new patients.
Yeah, we're so grateful for all you do for the
Love
community.
my job.
Good. Let's keep going with that. So what is the most rewarding part of your job?
Probably just so cliche, but certainly the most rewarding part of my job is getting feedback from patients that what we discussed and maybe some of the treatment options I offered worked.
Oh, yeah.
And that they feel better. And it could be anything from my bloating is better, my diarrhea that controlled my life, I couldn't leave the house, I couldn't go to church is better. I love that I can just help maintain and improve quality of life. So just getting that feedback, I love it.
Right,
Yeah,
that's
good.
great. So what about, do you have a particular patient story or experience that has stuck with you?
Yes, absolutely. I met a young girl, truly a girl. I mean, she was barely over 20, newly married with terrible ulcerative colitis, truly terrible. Her entire colon was involved. She was in and out of the hospital. We tried multiple different medications and really just couldn't find the right one to get her into remission. And that, unfortunately, that does happen every once in a while. She was back in the hospital needing to get nutrition through her veins, which can come with a whole host of complications. And I was recommending, and a surgeon that she had met with was recommending that she have her colon taken out. And that that is one of the treatments for ulcerative colitis is a total colectomy. And she just, for obvious reasons, did not want to have it done. But truly, it was killing her disease. And I say that because luckily she ultimately did undergo the surgery. She had an ostomy placed, so she has a bag, a permanent one. And she sent me pictures of her before her surgery, literally the day after her surgery, like 5 days after, 2 weeks after, and just the day after her surgery, she was a different person. And so we've stayed in touch. She's gone on to have 3 children with an ostomy, with this history of ulcerative colitis. She's done great. She's a huge advocate for patients with Crohn's and colitis because of her own story. And I just happened to meet her and take care of her. So I do reference her a lot when I meet young people, especially young women who are worried about having their chronic illness and potentially getting pregnant and having a family, that it can be done. We just have to take care of the disease state first.
Yeah. Wow. And what a life-changing blessing you were to her. So we often talk here at Williamson Health about just the different feel that we have here. Of course, patient-focused, the compassionate care, but also with a hometown kind of family touch. So how do you see that in your practice or throughout the hospital?
Absolutely. I mean, Williamson is the ultimate community hospital. We are taking care of people that I'm going to see at the grocery store. I'm taking care of my nurse's neighbor who referred her neighbor because she trusts me. I mean, it just is the ultimate community hospital. Williamson as a whole not only cares about taking care of patients' symptoms and illnesses at the time, but Williamson as a whole cares about educating the community, really getting out there and letting patients know we're here for you and here's what we can offer you. I mean, this podcast is a perfect example. And you all have supported me many times going out and giving talks, which I love because then patients come and say, I heard your talk and so interesting, or tell me more. I have this and I wouldn't have come if I didn't know X, Y, or Z that you talked about. So,
well, and I do think it's so important because, coming to the doctor often is scary. And for patients to be able to see you out in the community or hear or listen to you here on the podcast, it really kind of takes some of those complex issues, some of the embarrassing topics, and allows people to.
I mean, it's the best place I've ever worked. I mean, truly, it's the best place I've ever worked. I love it here. I'm so proud that I work here.
Dr. Lindsey, thank you for being here with me today. You make the GI tract so fun.
Thank you.
Yeah, it's always fun to hear you talk about it. We really appreciate it.
Thank you. Thanks for having me. I appreciate it.
Yeah.